For the next talk, I would like to invite Mr. Sujay Bhandari, who would be um, enlightening us on the psychosocial support for older patients with cancer, needs and solutions.
Yes. Hi, everyone. Okay. So, when I heard in the morning that we're already going to be talking about unmet needs, I was, wondering what am I going to talk about, finally, when my turn comes. And it seems like there is already a lot of awareness in terms of what there are unmet needs. There are, needs of geriatric patients which are not met. Um, it's important, however, for us to also locate our discussion in a context that discussions are happening every year, discussions are happening every day, we all talk with each other, but still there is a gap, right? There's still a gap over here of the needs which are unmet. And we think of social needs as something that we can delegate, to paraprofessionals, to allied professionals. But I think it is important that even the medical professionals realize that they are a part of the social need of the cancer patients. Um, it is important that when we talk about geriatric population, there are intersections of being part of an older adult population and then also being a part of individuals who have been diagnosed with cancer, and there's a lot of overlap in terms of the experiences they have, which is compounded by the ailment that they experience. Um, Already as individuals who are in their later adulthood, they experience neglect, social withdrawal, they experience routine changes, because they are older, they experience some sort of existential fears also. There's some sort of guilt and shame that they're being a burden to people in their family. And of course, they have to also deal with the physical and mental decline that they experience due to, again, as they age. And these are things that, of course, are further compounded when there is diagnosis of some sort of terminal illness, right? And it is important that we not just think about it as intersection of just age and being a patient of a terminal illness, but also there are questions of class, questions of caste, right? That comes in question of religion, okay? Because when it comes to social aspects, we cannot ignore these things because the way we express our social needs are not going to be uniform, right? Even something as simple as anxiety, right? When a person comes to you to talk about anxiety, they don't want to say कि मुझे anxiety हो रहा है. Especially older individuals who may not have that language to communicate their needs to you, they're going to say anxiety. Or they may say something like, कुछ तो दिल में धड़-धड़ जैसा हो रहा है मुझे. They may say, पेट दुखता है मेरा हमेशा, मुझे बहुत डर लग रहा है, right? The language that we speak don't necessarily have anchors in the language in which we learn our skills as professionals, right? So it is important then that when we talk about social needs, we acknowledge that there is a dearth in skills also, all right, from the side of professionals, all right, that needs to be addressed before we get into the social needs in the lives of the patients. Now, if we are to think of social needs, I can think of it in four dimensions. Instrumental needs. Do they have financial assistance? Do they have assistance to carry out their activities of daily living? Do they have tangible means of obtaining the resources they need in order to have effective treatment? We spoke about so many gadgets, we spoke about so many solutions over here, but what is the accessibility to these things, right? How many of you over here work in rural areas? By show of hands. Anyone? No one. Not now, but again, we may have shifted to cities because there are better opportunities, better infrastructure to work with, perhaps. And rural areas, where there isn't, infrastructure available for people. Like often, I called one of my students who also has now started working at Tata Memorial in terms of what is your experience of, the kind of people who come in, what is the experience of the social support that people need. And they say ki, especially when people come from rural areas, there is a sense of abandonment because they are basically leaving everything they have behind and coming to the city in order to, seek treatment over here. And this is basically their one shot at, some sort of chance at survival. And this is in case of, the space is not going to palliative, it's more curative section, mein, right? Palliative, mein, there is loss of hope, right? क्या करने का अभी, right? We have appraisal based support. Like, do the patients have means to evaluate their own actions, right? Do we tell patients how to gauge whether the treatment they've been prescribed, whether, whatever it is that we tell them to do as a part of the care, to know whether it's working or not, when to report, things to the doctor, okay, when to sometimes just, it may take time and be patient, right? Do they have means to seek self-affirmation, right? Are there ways in which we have asked the people, asked our patients, to kind of khud ko dilhasa dene ke liye, right? Have we provide some means, some ways of doing that? In terms of informational support, do they have someone to answer their questions? Because one of the biggest things when there's diagnosis is, what does this mean for me now, right? How many of you can, if I ask you right now for a recommendation of some sort of resources to give to someone who does not speak English, okay, who speaks in Hindi, how many of you can recommend me resources to, which will be comprehensive enough for an older geriatric patient to refer to and know what are the possibilities for them? Are there resources? No, there aren't. Do they know how to solve the problems that may encounter, right? To understand what to classify the problem. And that's what I just also spoke about in terms of we don't have the language, right? To classify the kind of problem we are facing. That of course can become confusing even for the practitioner to understand what is it that they're talking about, because again, the language in which we learn and the language in which people speak, there's a gap, right? Who can guide them in decision making? Now this is where, again, my question is, do we see ourselves as a part of the support system, as a social support system, or are we just as practitioners thinking कि मेरा काम medical professional का है, तो I will do the treatment medication part, and बाकी का will be handled by the social worker and psycho-oncologist, right? But for the patient, they are not exactly the ones who are prescribing medications, right? And as much as training an experienced psycho-oncologist would have received, it is eventually the medical professionals who will have a better idea about side effects, a better idea about what patients can expect in certain kind of treatments and what are the alternatives. The first point of contact, right, after social worker for the treatment part is a medical professional, right? So how much training do medical professionals get? How much importance is given to communication? Because science communication has now become a very budding field where being able to speak in a relay information in a manner that is universally understandable and amongst professionals we can communicate. We're having these meetings, great, but this is a very small section of the medical professionals that is they're here today, who care enough to turn up at today's meeting, or maybe even discussed amongst each other. Most of them are struggling to maybe even keep up with the patient volume, or even keep up with the kind of treatments that they're prescribing, working, not working, all these things. And then emotional support, right? um, do the patients feel loved, right? Because patients have lives before they came to the hospital. They have lived full lives, especially geriatric patients. They have seen so much. They may have undergone abuse. They may have undergone discrimination. They may have undergone economic hardships. They've had a life. Cancer की वजह से उसकी वजह से उनका difficulties नहीं आने वाला. They have already come with the complexity of emotional difficulties, of relational difficulties, right? So do they have people in their lives who care? Right? We ask कौन है घर पे संभालने के लिए, we try to find out घर पे कौन है, but the question is, are they people who they feel comfortable with, or are they people who they feel that okay, eventually वो लोग सोचेंगे कि okay, I'm burdening this person, but now they're my relatives, so I have to rely on them, और कोई option नहीं है मेरे पास, right? Do they have people who they can trust? Because often being in a state of terminal illness can put you in states where you may have entered a point in life which you would have never foreseen for yourself, of embarrassment, being in a state of weakness, of dependence, which you would have never imagined. You would have imagined certain things, of course, that would have come with old age, but the kind of dependency that comes with terminal illness is a very different thing altogether, right? So these are the kind of supports that we, need to talk about. All right. Again, there's awareness, but the question is, what are we doing with this awareness? So, psychosocial support is something that is relevant to treatment outcomes, because it is not just a matter of whether a person is going to take the medications or not, because there are so many other factors which come into picture in terms of treatment adherence, right? The motivational factors, there are social factors, affordability of medications. There are aids, yes, for trying to buy medications, but from what I understand, it does not cover everything. So what is their experience then to gather the finances to be able to get the support that they need, right? So these things come under the psychosocial support. Their experience of being able to seek help, seek finances, seek support is what we're talking about when we talk about psychosocial support. Yeah. So it is the availability of opportunities and structures, okay, which can fulfill needs that arise in individual's mind and environment, okay, and they can be anything related to their self-image, roles in the family, experience of health-related events. All these kind of things come under psychosocial support. And when we talk about psychosocial support for people who have been diagnosed with cancer, there's an additional question of, okay, now I don't have as much time as I thought I would have had to sort things out. There's an additional stigma also, there's an additional label also that I am sick now and I'm going to be seen as a sick person, right? And how does it affect this has shut down. The laptop is running out of battery, I think.
Maybe we can take a few questions for this part of the talk.
Sure.
No, it's hard to ask questions unless you know where does he want to go, with it.
So he's going to make a social support questionnaire. So I think the crux of the talk is that we don't have any way to assess our older patients' psychosocial needs, and we're trying to look to. So again, the genesis of my discussion with Sujay is that we have a social support questionnaire as part of the geriatric assessment, which is from the US, and that is ask, do you have somebody to talk to? Do you have somebody to take you to the hospital? Do you have somebody to cook your meals? And all patients have that here. So those are absolutely not the right questions. So when we found in our geriatric assessment, the social support domain, nobody was vulnerable because everybody had all of this. But our patients had other things. So my association with Sujay is how do we ask the right questions and develop a social support questionnaire for our geriatric oncology patients that is a relevant questionnaire. So this has led to the genesis. So that's where it is going. So if you want, you can ask that.
But I would love to, but I don't know. I don't want to interrupt you. I think you're.
No, it's okay. If you have a question, all right, okay. ठीक है. So as I said, there are things which are going well in terms of there is awareness. Definitely, there's availability of government aid to a certain extent. There's certainly there's an increase in availability of psycho-oncologists and professionals and other allied fields. There is a shift to a more collaborative approach where now all professionals are working together in order to provide care for the patients. But the question is, what could be done better, right? There needs to be training for communication, not just for psycho-oncologists and social workers, but also for medical professionals. Okay. There also needs to be some sort of standardization of care, right? Because there is so much subjectivity that comes in over here, but eventually, if our goal is to move towards providing some sort of universal standard for social support, then there should be communication. There needs to be some sort of common criteria that needs to be established. But of course, culture-specific criteria also needs to be taken into consideration when we are talking about regional differences, right? Increase in availability of caregiver training facilities in tier 1, tier 2 cities and rural areas. There are almost none when it comes to caregiving facilities, training. There are facilities which for people to admit patients in, but what about caregivers who want to learn how to take care of their loved ones who are terminally ill? And especially if it is someone who is an older patient, it's likely that they have kids who are working, who may not have the time to be at home the whole day, and especially if it is someone who cannot hire additional help. They don't have the finances for it. So what is it that they need to know in order to ensure that the person at home, while they're gone for work, what can be done to take care of them, right? There needs to be centers which provide information, for oncological care, because again, there is you can't have to just go to a doctor in the first go, because sometimes people, as someone said just today, ki Google karte hai sab log, and misinformation is very easy to spread. But if there is a credible source of information that is available to everyone, not just people who are English speaking, people who have a good handle over Hindi, Marathi, whatever regional language, but something that translates without using complex language to people is something that we need. Okay. There's more interdisciplinary research and sharing of information that is needed. Of course, as I said, we have a lot of discussions on this matter, but the question is how applicable is this research, how generalizable these researches are in order to provide the social support, how well it is translating, into the social support provision that is needed in the ground. So my suggestions, of course, would be increased research on social processes of treatment, not just the medical processes, designing a social care system, and fostering uniformity in value of life. The third one, it comes from a place where from what I understand, from what I hear, is often comes from the point of view that when a person is an older patient, there's less value given to their lives as compared to younger patients in oncological care. So trying to also move towards a place where we have a universal value to human life is something we would need in order for people to even start caring for providing social support to geriatric patients. So in terms of research, as I said, there needs to be evidence-based interventions design for social care. Assessments are needed. There are a lot of assessments out there, but I honestly am not very sure about, because one question when I met Vanita was, how will you assess validity of our questionnaire? How will we know that it is actually giving us the kind of information we need? Questionnaire banega, we have translation, but translation and accuracy, consistency in responses does not mean that it is actually measuring what we want to measure, right? So it is very important that if we use assessments, we do start thinking about its validity. Then in terms of care, what kind of care can we provide? Individual interventions, of course, a lot of us have spoken about. CBT, REBT, fine, but it's given too much importance, to be very honest. I remember a horrific viva where my student is like, schizophrenia ke liye CBT, REBT karenge. And I was like, please, I am not passing you with this kind of answer. There are a lot of other kind of intervention systems available in terms of existential therapy. There is dignity therapy. There is hope-based interventions. A lot of interventions in positive psychology, which is going to be difficult to quantify because not as concretely anchored in behavioral aspects as CBT, REBT traditionally is. But it is important to explore that because these are the kind of problems that people are facing in palliative care. They're facing problems of hope. They're facing problems of dignity. They're facing problems of what is my life about right now, right? Group interventions, support groups could be very helpful. So for those who can't afford, admitting people into palliative care full time or something like that, maybe group-based interventions could be helpful, where it could be interventions for patients, group-based interventions for patients who come together and talk about their experiences, or even for caregivers, because caregivers also experience a lot of stress, and for them, group-based interventions could be very helpful. And this can also be a very good way of inculcating skills in the caregivers, of geriatric cancer patients. And finally, when we talk about value of human life, it is important to understand the complexity of your patient's lives, not just from what are the variables that has been very prominently discussed in the medical field, but various variables which are not discussed in medical field. Economic class, caste, sexuality, gender, all these things matter a lot in terms of patient care, and this of course translates to even geriatric patient care. And as I said, it's important that in our discussions of value, we talk about dignity, we talk about hope, we talk about inclusion. And yeah, that is my talk. And thank you so much for the amazing work that TMH is doing with the patients and giving this platform for discussion. Yeah. Yes, please.
All right, so I wanted to ask about your thoughts on, you were saying how culturally it's different in India and we don't know about the validity of scales, right? So I'm just wondering, can you speak more towards those cultural variations? Like, for example, alienation, loneliness, and how these can be connected back to social support, and how do you propose to help measure those aspects?
Okay. So in terms of cultural variations, now, for example, let's talk about, I mean, a lot of you are from Mumbai, but for those who are not from Mumbai, so there are, your middle class suburban areas, and you have like your distant Vasai Virar side, Badlapur side, where you have people who are generally who belong to lower socioeconomic strata. So now here, the ideas of alienation, for example, there's alienation already being experienced when you belong to socioeconomic strata, which has anyway been marginalized, and that leads to a different way of dealing with such kind of situations where perhaps there already is support because marginalization kind of sometimes brings people together. And there is better social support. In fact, there's better coherence amongst individuals who belong to these communities as compared to, let's say, a suburban, Mumbai house from a middle class family, which actually may experience more isolation. We often think of individuals from marginalized communities, for example, as more, disenfranchised and with less, what do you say, um, means of seeking social support. But actually, we may actually have something to learn from how community building works over there and apply those principles maybe over here in our case of dealing with other sections of society too.
Okay. And I wanted to ask you about your thoughts on participatory action research. I mean, is that an angle that you intend to take?
Could you clarify what you mean by participatory
So
action?
it's basically where you have the questionnaires are co-created by the patients and the caregivers themselves. So
Absolutely.
that's, yes.
Yeah, because I don't think you should have just one expert, sitting in the armchair and thinking about what are the possibilities out there. Even the social support scale that we are building, we are trying to first. We're starting with the qualitative study first to understand the experiences of the patients, and from there we are generating items instead of thinking theoretically speaking what are
No,
the
but
possible
the
items.
thing is that, when you're designing that and then you're also going to the next phase, so this approach will allow for the participants themselves to also weigh in on the scale, right?
Huh, yeah, yeah,
So
yeah.
it's an active, they become co-creators of that scale.
Yeah, so face validity, for example, is something that we are going to look into, and also having some sort of forward and backward translations from the patients in terms of whether they're understanding the items well, whether it's translating into what they are, they are reading well or not, is something that we are taking
And
into
your expert
consideration.
group also can be patients who will then
Yeah, yeah,
also provide you
absolutely, yeah,
feedback,
yeah,
right?
yeah.
Yeah, but I think also, sorry, just one last thing is
Sure.
that the concept of social communication is something that, is also very important to kind of explore because as you were saying,
Yeah.
economic variation does not play a role in terms of the lack of or the need for communication within oneself. And more than isolation, alienation is also an issue that, stigma and all
Yes,
those kind of things
absolutely.
need to also be embedded into a social support questionnaire within India especially. So that's something to also explore, right?
Yes, true. I completely agree with that. And also because I think often there is an entrenchment of superiority that, I have seen. So because I teach clinical psychology, so I've seen that psychology, psychiatry, के साथ जब interactions होता है, there's always a sense of hierarchy that's there. I think a more collaborative approach is a better way to go
Yeah.
rather than a hierarchical approach, and that's where it is important that that's why I said that communication needs to be given even for medical professionals. We can't shirk responsibilities saying that our job is just medical professionals, so we will not deal with the communication part. Yeah.
Jay, I'll just ask a quick question.
Yeah, sure.
From a, in the clinic scenario, which many would correlate. So say we've got a late 50, 60-year-old patient accompanied by three sons, three daughter-in-laws, an extended family, clearly very good social support. Maybe.
That's the question. Yeah.
Yeah, yeah. But doesn't do well, and we can see during the rounds that there is a say level of anxiety and negativity and various things which are happening. And another scenario where we have an 80-year-old lady coming with just one teenage grandson, gets a super major surgery and goes out of the hospital without any events. We often talk about resilience. Is that an objective thing? Is it something which can be measured? That's one. Because I think particularly for the Indian population, if there is an objective way of measuring resilience, or if that can be devised, that will be very relevant for our population because many of our patients do well despite the odds. That's one. The second thing is that we always tend to go together as a psychosocial. I mean, on our talks and things and measurements are psychosocial, but I think for our population, probably the psycho and the social part are different. They are
Okay.
two different parallel and they could be divergent as well.
Okay.
So,
Disclaimer, the topic I gave Sujay was social. He added the psycho part.
Yeah, resilience, yes. I mean, there are definitely a lot of constructs on resilience, measurable ones. India, not very sure. But also, an interesting point I came across a few days earlier. We were having a workshop on ground realities of mental health. About resilience, sometimes resilience ends up becoming a barrier to communicate lack of support, because we can't really, when there is families will not pay attention when you are holding on and you're not saying anything about lack of support, and you may that may qualify as a high resilience thing, and that of course becomes easier to think of again. It's easier to put the responsibility on the individual and leave it at that, because it is difficult to involve the family, because there's a whole complex, dynamics of people that is much more difficult to deal with. But resilience, of course, could be helpful in terms of helping with maybe treatment adherence and things like that, so that people don't really give up easily. But it can be a double-edged sword in terms of whether or not then are they holding back from seeking support that they need. Yeah.
Thank you, Sujay.
Yes.
Thank you for a nice topic. Actually, I would like to make a small comment. This is really a good initiative for psychosocial assessment, But when we consider about the psychosocial assessment, so we need to, and this is definitely good, but we need to consider that the feasibility, But when patient comes, first that patient is elderly, he has a lot of comorbidities. He advised with some chemotherapy, So, in my setup, I can say that we do some psychosocial assay without scale and that support also. I can give a small example and briefly that as you were as somebody were telling that an old lady that he doesn't have a son. She has that son and that daughter, but she always attends with a grandson and he is just 12 years old. So he stopped his schooling. He's discontinued his schooling. He's from West Bengal.
Okay.
And so that we need to speak because that child that he doesn't know, he's not that much aware of the importance about his continuing of education. So we need to support and psychoeducate that why is here and that somebody should be with her.
Yes.
Somebody should be with us so that he can continue his schooling. Second thing, that some patient that children that they are not with the old patient. I have seen some patient that recently that they elderly patient, he has three sons, they are living in Mumbai, they are staying in Mumbai, but still patient is staying on road. So we highlight those issues, we help them. Somebody has financial support so that we that navigate through our medical social worker and that we have continued follow up whether that issues is been resolved. So what I'm intend to say that we do some sort of psychosocial assessment along with support. Thank
Okay.
you.
Yeah. Thank you so much for it. One last thing I'd just like to add, which kind of relates to my point of trying to anchor this meeting or anchor this talks in some some sort of context, is that very important point that Vanita had made right in the beginning of the first talk was institutional incentive and patient advocacy. We cannot expect any sort of social support pay difference to be made if we just discuss it and if we just talk about. I think there's often so I teach and there's of course medical professionals. I think both these professionals are considered noble, and this nobility is associated with a lot of sacrifice constantly, and there's a sort of guilt that's associated with asking for better infrastructure, because it's always seen as something, oh, you're a noble person, you should be dedicating your life. But there are certain structural realities which cannot work without any sort of aid, any sort of funding. And it is important that as a fraternity, that we do when we are in, and I'm sure all of us are in important positions, we do have to push. We have to push for better, because we can reach places, where our voices can be heard by, in policy making, and it is important that we do talk about it, and give these things the spotlight that it needs. So yeah, that's all I have to speak about today. Thank you.
Yeah, thank you then. So